Hello, hello, and welcome to today's episode of Talking All Things Cardiopulm. I am your host, Dr. Rachel Burriesci. Before we start our episode, let's chat about Jane. Many of you are familiar with the name, but if you're new to it, Jane app is a clinic management software and our show sponsor. The Jane team knows that no-shows and late cancellation pose a real challenge for clinics, and they want to help. One way that they do this is by making it easy for you to create effective policies that can be enabled and communicated to your patients. The first policy is an online booking payment policy. When integrated with Jane Payments, you have the option to request a card on file or a deposit at the time of booking. You can also enable credit card collection directly into your intake forms for an extra layer of no-show prevention. The next policy is a cancellation policy, which you can request your patients acknowledge and consent to. Jane will also reiterate your cancellation policy in future appointment-related emails sent to your patients, so you won't have to remind them. If you want to see these features in action, you can book a personalized demo at jane.app/payments. If you're ready to sign up for Jane account, don't forget to mention my 1-month grace period code, Cardiopulm1MO. Thanks again, Jane. Hello, hello, and happy Wednesday. If you cannot hear that siren in the back, that's wonderful. If you can, it is the first Wednesday of the month. So I'm a little late on my recording this week. And I'm in the Midwest, so that is the tornado siren, practicing in the event that there is a real tornado. So if you're from the Midwest, you're like, yeah, this is like happens the first of every Wednesday of the month, and it's happened our whole life. Well, I am not from here. I'm from New York, and we don't have tornado sirens that are like monthly reminders that there could be a tornado. So when we moved to Kansas City, I was home, I think, by myself the first Wednesday that this happened. And I called my mother-in-law in a panic and asked, do I need to go into the basement? Like, is there a tornado coming? What is happening? And then I learned very quickly that this is just kind of part of the routine. So first Wednesday of the month, we have our tornado sirens. We have been very fortunate so far. A lot of storms have just missed this year. And I know there's been some significant havoc and tornadoes and rain and flooding. So we've been lucked out. And I am actually really hesitant to say that. So just going to keep putting that good energy into the universe. What else? I had something else I was going to tell you, and it's gone. I started my seeds last week, this week, and those babies are popping. They usually take about like 7 to 10 days to germinate. They start to see something, and I swear within like 2 to 3 days, these things were starting to pop out. And every half a day is like a new plant has emerged or grown, and it's just amazing. So I'm super excited to get the garden going and hoping to sort of get that prepped maybe this weekend. So a little excited to get my hands in the garden and start that whole process. The garden's really definitely a what's that word? I don't want to say safe space. That's not what I want to say. It's one of those hobbies that just really, I don't know, grounds you a bit, has a lot of culture for me. I've talked about gardening in the past. So I really enjoy it. And honestly, being able to share vegetables and fruit with friends and family, so important to me, just kind of part of my culture. And there is nothing like the flavor. And I've talked about this quite, probably ad nauseum if you have listened to me for a while. There is nothing like growing your own vegetables compared to what you get at the grocery store. It doesn't even compare, right? Like a tomato actually tastes like a tomato. And when you finally have that, you're like, wow, this is what it's supposed to be. So I'm super excited. I'm hoping I have a good growing season this year. Last year, our season lasted pretty long. So got a, great use out of the garden. And I'm actually on time this year with my seeds. So I'm hoping they will be strong enough to put directly into the ground and maybe not have to buy any starter plants. So that is, that's always the goal. It's always what we're aiming for. So let's jump into cardiopulm, shall we? I've had a lot of questions about sternal precautions recently. Probably over the last few months, I've had a couple of people reach out and ask what our standard precautions are and have I ever heard of keep your move in the tube. And so I wanted to discuss typical or standard precautions and then maybe some new age type precautions that might exist. And we'll speak about specific articles and kind of compare some differences along the way. So first and foremost, there are no standard precautions in the sense that it's not nationwide, it's not worldwide. Every hospital is a little different, surgeons are a little bit different, and you're going to see a lot of variety in sternal precautions. So actually, when I moved to Kansas City, one of the first things I did when I moved here was reach out to local hospitals and ask what their sternal precautions were, because I was moving into faculty and I wanted to educate not just on what's typical, but what they might see locally, especially as they go out on clinic. And so there's a lot of overlap, but there are some nuances. When I was in Michigan, I worked at 2 hospitals that were 1 mile apart from each other. And they had some of the same surgeons. So like if I was working over in private sector, I would have a surgeon doing surgery there. And then I was in the VA, the same surgeon might be performing the same cardiothoracic cabbage here. Same surgeon, different precautions. So 1 mile apart. In one hospital, the precautions were no pushing, pulling, lifting greater than 5 pounds. In the other hospital was greater than 10, starting. So, nuance. My recommendation, first and foremost, before anything else I say in this episode, is check with your facility's standard. Check with your surgeons. You might have 5 different surgeons and maybe they have different precautions. So wherever you're working, you want to know what the precautions are for that surgery, for that line, tube, or device, period. Because there are differences per hospital, per physician. With that being said, there is a lot of similarity. So I'll just go through some typical sternal precautions. So first and foremost, no pushing, pulling, lifting greater than 5 to 10 pounds is usually where the precautions start. Some will progress the precautions every month by 5 pounds. Some will progress every month more than 5 pounds. So again, it's super important to know. Typical precautions last anywhere between 6 and 12 weeks. 12 weeks in my experience has been most typical. So that 3-month mark is typically where those precautions get lifted. When I say no lifting, pushing, pulling, I am not just suggesting weights and objects. I am also suggesting use of arms with transfers, bed mobility, sit to stands, all of the things. And that's really where problem can set in. And we'll get to that in a bit. Typically, I shouldn't say typically on this one. Sometimes there's a precaution on range of motion. So in the places I have worked, this precaution has not existed, but I know it does exist. So shoulder range of motion is sometimes part of the precaution. And sometimes shoulder precautions are no shoulder flexion or abduction greater than 90 degrees. Again, I have never worked in a hospital that had that precaution for standard sternotomies. Typically, I can't even say typically. Sometimes shoulder range of motion is part of the post-op exercise plan. So every place I have worked in my residency in the private sector hospital that I was at, previously was paired breathing exercises post cardiothoracic surgery. So that would include shoulder flexion, horizontal ABA deduction, shoulder shrugs, scap retraction, protraction with paired breathing. That would be a very distinct, right? That would be very distinct difference between 2 sets of precautions. One is encouraging shoulder range of motion. One is saying you can't move your arms above your 90-degree mark. With that being said, in the places I have worked, actually, I want to say one of two, so don't hold me to it. I'm not putting hospital names to this for that reason. There was range of motion precautions when you had a redo sternotomy. So for instance, maybe you had a congenital heart disease and you had open heart surgery when you were a child, and now this is your second or maybe third sternotomy. That would be considered a redo. And so there is higher risk with redo sternotomies and healing, and therefore they might be more strict with their range of motion precautions. So in at least one of the two prior, and now I'll say 2 of 3, we had shoulder restrictions with redo sternotomies. So no shoulder flexion, abduction greater than 90 degrees. We'll talk about the problems with these precautions in a minute. I just kind of want to get through some of the typical. Some shoulder range of motion precautions state that if you are going to do overhead motion, then it is recommended that you do bilateral upper extremity motion versus unilateral. I can get behind this one because if we do more unilateral, we might get more rotation at the sternum, and you could potentially have more torsion at the incision, maybe at the actual healing bone structure. But same thing without any weight, questionable. I think when you start to incorporate trunk rotation with that, then you might have some concerns, but, kind of depends on where you're at. I saw in one article, actually, as I was reviewing this, said the exact opposite. And the opposite was that you shouldn't bilaterally raise and you should only unilaterally raise. This is why I'm telling you there is no standard. You have to confirm the standard with your hospital that you're working at. And if you're in the outpatient setting, then you should be confirming it with the physician that did the surgery. Typically no driving. And again, that time frame is usually around 12 weeks, sometimes less, but 3 months is like a very common time frame that I see. And then any sort of airway clearance should be splinting with coughing. Some people recommend holding a pillow across the chest. Some people recommend using what's called a heart hugger, which is kind of like a vest type contraption with 2 handles. And so especially if you're progressing and maybe you're at 8-week mark, I don't know, and you don't carry your pillow everywhere, you would have the ability to hold the handles and then apply appropriate pressure for splinting. So I'm just going to recap the typical, because I know I threw some nuance in there. So typically you might see lifting precautions, so no lifting, pushing, pulling greater than 5 to 10 pounds. Typically that increases about 5 to 10 pounds per month for up to 12 weeks or 3 months. Typically, you'll see recommendation to have bilateral upper extremity movement if you're doing overhead movement. Some hospitals will restrict shoulder range of motion to about 90 degrees for shoulder flexion, horizontal abduction. Some hospitals or surgeons will only place those restrictions if the person has a reduced sternotomy. And lastly, we typically are splinting with our coughing and have a driving restriction. It depends. That answer sucks, right? Like people always ask these questions and I'm like, it depends. And so in this case, it depends on your hospital, it depends on your surgeon, it depends on what has been in place for X number of years. Now, a lot of people ask, are these sternal precautions too cautious? Probably. And when you look across the research and people trying to demonstrate the amount of torsion placed on the sternum with specific movements, it's risk benefit. So I think the reason why some of these precautions have been put in place is if you do have dehiscence of the incision, if you end up with some sort of infection, if you end up with sternal instability, and then I'm going to probably mess up the pronunciation of this, mediastinitis can really have significant impact on morbidity and potentially mortality. So although the risk is very low, and I believe, and I'm going to pull up a stat, it was like 0.8%. So let me see if I can pull it quick. I have some notes on the side here. Of course, I'm not going to find it when I need it, but it was something like between 0.8 and 12%. 12% is too high. It was a small number, risk of complications postoperatively. So then what's the concern with these strict precautions? So I'll tell you from personal experience, the primary problem with these precautions is progression of the patient, especially patients that live alone. So what you tend to see is patients who are post-sternotomy for any reason, right? Whether it's post-CABG, post-AVR, post-MVR, post-heart transplant, even post-VAD, you have a sternotomy. So I guess I should back up probably to the start of this podcast and just simply state that if you have a sternotomy, then you will have sternal precautions. So I probably should have started with that as an opening statement. I just kind of jumped right on in. I know I have the stat like very close to the top. But really the problem that you see in the acute care setting is the 5 to 10 pound weight restriction. So I want to say in the last, 5 to 10 years, places I've worked have been closer to the 10 pound mark. So the place I currently work has a 10 pound lifting restriction. And just for some, guidance on what 10 pounds is in regular life, that's about a gallon of milk. I had an engineer once correct me. I think a gallon of milk is like 8.72 something pounds. But we usually say a gallon of milk is a good gauge as to what 10 pounds is. So if you live alone, what can you do in your daily life safely without breaking a 10 pound lifting restriction? Could you cook a meal for yourself? Could you do the laundry? Could you, fill in the blank? Then you throw range of motion precautions in. And if you're telling patients they can't do anything overhead, well, now we're eliminating things like dressing, washing your hair, reaching for something in the cabinet, whatever it might be. But the big one, personally, that I see is getting out of bed, standing up from a chair. If you have no lifting, pulling, pushing restrictions greater than 5 to 10 pounds, then you have to instruct your patient that they cannot utilize their arms to push up from a bed or push up from a chair with their transfers. Now, what happens when the person lives alone? If the person lives alone, then that person needs to be independent with bed mobility, supine to sit transfers, sit to stands at minimum, right? Because if they are not independent with those tasks and they have no one in their home to assist them, how are they getting out of the bed, out of a chair, off a toilet, all of the things? And so that could very much be the reason why this patient ends up going to a subacute or acute rehab. For people in the Midwest, we typically say SNF versus acute rehab. Lots of verbiage stuff. That's a big deal, right? So a lot of these surgeons don't want their patients to go to a SNF because it's going to increase their risk of infection. They're likely not going to do as much. Maybe. I don't know. It depends on the place that they're going to. But there is risk for not going home. But there is also risk to go home because they can't physically take care of themselves. Another situation is our older patients. If, let's say, you have an 80-year-old patient and their spouse is also in their 80s, maybe not mobilizing well themselves, they're not going to be able to physically assist that person out of bed. So maybe they need to at least be a standby assist, right? To physically do the things safely. That's a hard ask. This brings me to a different topic, which I really wasn't planning on talking about, but here we are. If you have the opportunity to hold pre-op classes, this is the exact reason why it is so beneficial. Many of these patients don't know going into surgery what their post-op precautions will be. Knowing that they cannot utilize their arms for supine to sit, sit to stand, is a game changer. And if they have weeks to practice at home before they have an incision, a midline incision that is painful, it can be very beneficial. And they might be able to practice that for days, weeks, whatever it might be, and potentially be ready for discharge then. Or have strategies, right? Or maybe plan. So discharging is a big limitation to these precautions. Can they discharge home? It depends on their physical ability maintaining said precautions. I think once you throw in range of motion precautions on top of the lifting precautions, it gets a little bit more dicey. The other piece of it is fear. There's a lot of fear post-sternotomies that they're going to do something to hurt said incision, to hurt the healing process. And so they have a little bit of fear-based movement. They're worried that, they do too much, if whatever it might be, can hurt their incision. And so that can lead to decreased function overall, which can lead to a decline. Maybe even if they make it home. Range of motion restrictions, right, could result in limitation of range of motion later on, especially if we now have an incision, we have tightening of the skin around that incision area, very much can affect chest wall mobility, shoulder mobility. And then if you add a precaution on top of it to potentially maybe enhance fear and or just not move the shoulders in our already probably aging population, it's going to have a compound effect on function, potentially long-term. Driving, I usually leave that one. I usually refer to the docs on that because it changes. It's different. Again, I worked in two hospitals a mile apart from each other, and their driving restrictions were different. So just ask. And if you know that answer, then you can relay it on, obviously. The other piece of are these precautions too strict comes when we get into airway clearance techniques. So we encourage our patients to cough post-operatively. It's like part of my education. I make patients huff cough. I teach them how to splint. I teach them how to cough. I mean, we're not doing reps upon reps upon reps, but it is part of the education and it's part of their daily routine. Fun fact, a cough generates about 60 pounds of pressure to the sternum. A sneeze generates about 90 pounds of pressure to the sternum. So one of the main articles that I'm going to refer to is a 2016 article that came out of Baylor. And they actually did ultrasound looking at sternal movement with specific activities. So they had patients do simulated lawnmower where they were pushing, pulling forces 36 to 39 pounds. And this was around 3 to 7 weeks post-CABG. And it did not negatively affect the sternal incision per this article. They also had patients pull out a dishwasher rack at about 5 pounds, removing a gallon of milk from the fridge, 10 pounds, pushing a glass door open to exit the hospital, 22 pounds, and then coughing, sneezing. They even did a simulation where lifting 2 20-pound weights simultaneously created less force on the sternum than a cough. So then you really have to ask, are these precautions really too stringent? And then where do you start to loosen the reins? And this is where questions start to come in. Another piece of the puzzle is that when patients do have sternal complications postoperatively, there are risk factors associated with it, including diabetes, obesity, smoking. Smoking's huge, right? Smoking affects healing. So there are things that can potentially put someone in a higher risk category. And then you could further ask the question, well, should we have different precautions for different people? So this concept isn't new. The first time I started learning about this was in my residency program. So I was in residency in 2013, summer 2013 to 2014, and we were already talking about modification of sternal precautions back then. That's over 10 years ago, right? So we're right around that 10-year mark already. So the first article that I'm aware of, and obviously, if you have information that goes even further back, let me know. My first article that I'm aware of is from Dr. Cahalan from 2011. And he did an article, and I think I wrote down the title of that article, Sternal Precautions, Is a Time for a Change, Precautions versus Restrictions. So he was literally talking about the same topic in 2011. Okay, 13 years ago, this was already a conversation. And the conversation is similar. So I really enjoy this article because he kind of goes through the history of change over time in medicine and how we look at even, for instance, exercise post MI versus like bed rest and how that changed and kind of like what all of that looked like. First they said exercise was good, then it was more bed rest, and they realized we had higher thrombus effects. So then we were sitting up in the chair and that was showing good progress. And as you know now, these patients are mobilizing earlier and earlier and earlier because movement is medicine, right? So there's change that happens through history, and things sometimes stay in place because maybe we don't have a better answer yet or a way to be consistent because humans are inherently different. So Dr. Cahalan actually goes through risk factors in detail, and he looks at primary versus secondary risk factors. And things in the primary risk factor category include obesity, COPD, right? So thinking increased AP diameter, maybe increased coughing. Patients that had internal mammary artery grafting, higher risk. Diabetes, reduced sternotomies, if they had long cardiopulmonary bypass time, if they had blood transfusions, if they had a higher New York Heart Association class disability score, again, smoking, PVD, and prolonged mechanical ventilation time, and being a female gender with a larger breast size. You think about this, patients postoperatively, they don't really have support either. So thinking about the weight that could be pulling on the skin, the incision, really does play a role. Secondary risk, osteoporosis, longer ICU time, using staples for closure. Now, I haven't seen staples in a sternotomy in quite some time. It's more of like a glue. So I think surgical procedure, which he also talks about in this article, plays a role. So at that time, in 2011, they were already looking at sternal movement with specific arm range of motion and how much movement was occurring at the sternum. And in that article, they showed that overhead bilateral upper extremity movement caused the least amount of movement at the sternum. In 2011, things that did cause increased amount of sternum was using the arms to perform a sit to stand. I think there's nuance there in position of arms on the rails of the chair, right? So like there's so many things that can play a role here. Or moving from supine to short sit. So if I'm thinking about this person is laying on their back and they're going into a short sit position, Where are their arms pushing up from? Are they from behind? Are they from the side? So extension, shoulder extension, is sometimes on the list of precautions, right? Because we're going to be putting increased strain on the anterior chest wall. One thing that Dr. Kalin, went into in this article was the surgical procedure and how certain procedures did better post-operatively and had less risk associated with mediastinitis, infection, wounds, that kind of dehiscence. And so they showed that using plates and cables were superior to the wire system. So in 2011, they were already having conversation about sternal precautions potentially being too stringent. So in this article, and I'll link the article so that you can, further look into it, or I should say the citation so that you could look it up and grab the article. He broke down sternal precautions into an algorithm, looking at the difference between high risk versus moderate risk and low risk. And in that, he had different criteria to put you at high risk, mod, and low risk. And then basically, they would follow maybe tighter precautions with the high risk versus the low risk. And there would be a reassessment at the 2-week mark. And if things are looking good and healing is occurring without clicking, incisional, dehiscence, all the things, then they would move to the next category. And so I think this is a great approach because you're literally including the risks associated with the concern, right? So in 2011, Dr. Cahalan put out this awesome article already talking about this. In 2016, and I think this is the earliest form, and I will double check myself because I was looking yesterday when I was prepping this. I thought it was earlier than 2016 because I was still in my residency world, and I thought I was a resident when this Baylor article came out. So in 2016, and I'm going to refer to this article, and I thought I put all of my et als in here. Okay. I have it. Hold on. Yes. Okay. So Adams et al., an alternative approach to prescribing sternal precautions after median sternotomy, quote, keep your move in the tube. So keep your move in the tube is a trademark term for these precautions. I just want to make that as a blanket statement. So if you are thinking about changing precautions in your hospital, going to this type of procedure, you would have to contact Baylor and collaborate to some degree. I don't know the whole process, but that's how that would work. So I'm going to reference this Baylor article, and I think it was a great article. So in 2016, right, we have some time that these things were already starting to be talked about. And so just like rule of thumb, research takes a long time to be put into practice. And I think we know that at this point. And I think within institutions, it's hard to make change. So even if you really want to get this thing going, like you have to be part of the conversation. I think it starts at that. And then you can bring forth articles like this Baylor article to help start to make conversation about making change and then potentially get it implemented. So these things don't happen overnight, obviously. And a lot of people will ask me, like, how come I've never heard of this? I don't know. I mean, I don't. So I know a lot of people talk about how we can do a better job of getting information out to the clinicians, out to the people. And it's part of the reason why I wanted to talk about this today, because there is great research out there showing safety with more lenient precautions, such as sternal precautions. So this Baylor article in 2016 actually looked at sternal movement with the activities we talked about earlier. push-pull on the lawnmower, pulling out a dishwasher rack, lifting a gallon of milk, coughing, sneezing, all of the things. They also talked about those risk factors. And then they were trying to figure out, I think themselves, based on the article discussion, how could they implement less strict precautions? And they kind of came to a conclusion that said that they really didn't want to do it based on time, so like a time limit. And they realized that there was going to be some potential differences between patients. But one of the things that I really loved in this article was at the start of it, they literally say, before implementing this new protocol, they would teach their patients about the anatomy. And I love this. This is something that we did in cardiac rehab. We literally held lectures for the patients to understand the anatomy for cardiac and pulmonary rehab. It is very empowering to give knowledge to the patient, to allow them to understand what was done, how it works. It gives them a little security. You can teach them the nuance of the surgery, the anatomical structures, explain why you can and cannot do something. And I think that really holds a ton of weight for the patient. And I think it helps decrease the fear. So the general essence of keep your move in the tube is that you're going to decrease lever arms. So essentially, you're able to utilize your arms with transfer techniques while staying close to the body so that you have basically a green light versus red light movements. And this essentially would allow patients to use both arms to go from side lying to sit while keeping arms close to the body. This would allow the patient to go sit to stand, pushing up from the chair with instruction on where to place the shoulder girdle and where to place the hands so that you're decreasing lever arm to the sternum, so that you're decreasing force to the sternum, but allowing the patient to utilize their arms to potentially help with that transfer. So I think there's so much good in this protocol. And I really thought more hospitals and institutions across the country would have already implemented this. I have not worked at an institution that truly used this protocol. So it's out there. I educated my DPT students on standard precautions versus the Cahalan article versus this Baylor article. And there's one more that I'm going to talk about that's from Australia or New Zealand, or just Australia. I think it was both. And benefits, right? So I think this is a conversation that we can be having with our interdisciplinary team, but it has to be a conversation. It has to be interdisciplinary. I think if you could get more institutions involved, you would be able to see a higher benefit, or you could see the outcome a little bit more clearly. So 2016 article was kind of the starting point, but I think it was a great starting point. I think the protocol is very clear. I think it's easy to use. Essentially, you are allowing the use of bilateral upper extremities while keeping your arms at a close proximity to the body while loading the upper extremities. And I think that's kind of the point there, is the loading. Even discussion on how to open a door, like pushing a door open, and again, keeping arms close to the body. So it's not outstretched arms placing high force on that sternum. Even cues on how to push a wheelchair, right? So think about how much functionality comes into this, and then the likelihood that these patients might be able to discharge to home versus to a SNF or an acute rehab facility. Really, really a big question. In 2017, it is Australia and New Zealand, came out with a study protocol called the Sternal Management Accelerated Recovery Trial, called SMART. That's an acronym, which looked basically at standard restrictive precautions versus modified precautions. And this article did a really good job about talking about the lack of standardization worldwide, but essentially that, we have similar precautions that are limiting. And here's my stat that I was looking for. Sternal complications noted to be between 0.4 and 8% worldwide. It's pretty close. And that is involved in infection, instability, and mediastinitis. So obviously the complications are a concern. They lead to mortality, morbidity, increased length of stay, increased healthcare costs, all the things. So you can understand why there is caution in creating these precautions. This study also looked at movement of the sternal edges with specific movements, and they had an ultrasound to basically assess the level of movement with different tasks. And same thing, they basically noted that upper limb use and trunk tasks only cause less than 2 millimeters of movement at the sternal edges based on ultrasound technology. And so they wanted to do a similar thing where they looked at their standard precautions versus these potentially decreased or lesser strict precautions. So the intervention group used both arms and kept them close to the body for lifting objects, sitting up out of bed, standing from a chair. They would also avoid pushing or pulling with a one arm, and they would use pain and discomfort as a guide for safety of their activities. They would also continue to support their chests while coughing, avoid stretching arms backward with one or both arms. And so that was their intervention of precautions. Their standard precautions were very similar to what we've already discussed. So their original article was just the protocol. They didn't have any outcomes, and their outcomes came out in 2018. And so looking at the 2018 outcomes, they were looking at short physical performance battery, functional difficulties questionnaire, hand grip strength, visual pain analog scale. They had a Tampa scale of kinesiophobia and SF36, and sternal stability scale, I believe it's 0 to 4 scale. They didn't have significant differences between the groups. Each group had one sternal wound complication in both the intervention and the standard, but they really didn't show benefit or change with cautious versus not cautious. So I was a little surprised by that. If I had to put my 2 pennies on this one, I would say potentially their outcome choices was part of it. I think if maybe they looked at discharge location or length of stay, potentially that could have shown a difference in change. I was most surprised that the kinesiophobia scale wasn't significant. I thought for sure that was going to be the big difference. Like people were less afraid to move. Apparently it was really no significant changes. So, you can take that for what it is, whether it's not showing any worse harm, that could be part of it. But in that study, it wasn't showing any significant benefit based on the outcomes. I didn't search to see if they kept going. I just saw the 2017 and the 2018 study. And that 2017 study was one that I also discussed in my prior, lectures. Most recently, there was another study, and this was by, I think it's Gatch et al. And they're also using the keep your move in the tube, safely increases discharge home following cardiac surgery. So they're using the KMIT, the keep your move in the tube protocol. And they had some pretty good results. So they were in a 600 bed level 1 trauma center, and I believe 1,104. I thought it was about 1,104 met study criteria, and they were split into standard versus protocol. And their primary outcome was discharge location. They also looked at complications of sternal wound, and they looked at independence with mobility, which I thought was so important. So basically, the protocol group were able to achieve independent or MODI for bed mobility, 49% versus 11%. That's significant. Or transfers, 66% versus 34%. So 3 to 4 times or 7.5 times higher odds of actually meeting independence with the less restrictive precaution. I think that's huge. This is going to potentially be that thing that helps move the needle, right? So I think anytime we can implement and show progress, and the outcome I think that was utilized in this article was very beneficial, because this is what's holding patients back and prolonging their healthcare cost, right? So such a good article. I'm going to link all three, the citation for them, so you can take a deeper read. I really just did a brief overview. Hopefully I did it justice. But same thing in this article. No significant difference in incidence of sternal wound complication. So safety and improving independence and discharge home was 3 times higher in the KMIT group. That's huge. And PT was discontinued before discharge 4 times higher, meaning PTs were able to discontinue them from service before they actually left the hospital. And so there was even some nuance in that discussion, which then leaves the PT staff to see other patients that don't need them any longer, right? Because they're hitting transfer levels of independent, which is awesome. So this, I think, holds so much weight. I think that initial Baylor article was like opening the door. And I think Cahalan hit it on the head even further back. So this stuff takes time to make change, but now we have more information. And so if this is something you're trying to implement in your hospital, go through the channels, start to implement, have discussions, have these articles as, the starting point, reach out to Baylor, do all the things so that you can start helping to move the needle. I don't know what the percent of hospitals that use this protocol is, but I don't think it's high enough. And I think this can make profound change. So read these articles. I think there's so much benefit. I think we need to be part of the conversation. And this is part of it, right? So having access or even awareness that this exists is huge. So hopefully this was helpful for you. Like I said, I will throw some citations in the show notes. Reach out to me if you have any questions. Let me know if this was helpful for you. Let me know if this is something that you've been looking into. Would love to hear about it. Let me know what your sternal precautions are wherever you're at, because I am always interested. One of these articles did like a review. I think it was Cahalan in 2011. He reached out to multiple facilities and had them like laid out, and there was just differences between each one. So it's not standard now, it's just restrictive. So maybe there is a way to lessen the restrictions to get more out of that patient and get them home faster and also safer, right? Maybe take some of the fear out of movement, which I think can help patients long term. All right, I hope that was helpful for you. Reach out to me if you have any questions on Instagram, on DMs, shoot me a text. And I think that's all I have for you. So I hope you all have a wonderful day. And whatever you have to do, get after it.